is Rima Baripan, and I will introduce to you summary of a clinical trial. So I just do a mapping of a clinical trial so we can understand all these contents. So the first one, I will talk about the aim of a clinical trial outcomes. So why we do the clinical trial? Actually, we do the clinical trials because it's important for the treatment, diagnosis, screening, preventing, for the health science, for the basics of the health science. That is the important of the clinical trial. But here I said aim of a clinical trial outcomes. I mean the results of a clinical trial should be significant, relevance, internal validity, external validity. That's mean the results and the outcomes of a clinical trial should be significant. And what I mean here exactly by the significant, that they are just has an effect, and relevance, that's mean they are relevant to the clinical trial, relevant to the goal of this clinical trial, like treatment of a cancer or something. Internal validity, that's mean the measure, the accuracy of the measurement that we use. And the external validity, generalizability, that's mean how can the effect on whole population, not a smaller group or something. So the outcomes of a clinical trial should be significant, relevance, internal validity, external validity, and we understand all these things. Now we go to the clinical study types. So the clinical study types subdivided into two types: interventional and observational. Observational, we can say non-interventional. And when I said interventional, that's mean we do something to the participants or to the subjects, like we give him, for example, a treatment or a drug, and he took this drug, intervene, that is something that enter his body of the participants. So the interventional subdivided into two types: controlled and uncontrolled. When I say uncontrolled, that's mean there is no control group, like a single arm, like we do the treatment or we give the treatment to this group, and the group itself took the treatment and control at the same time, so there is no control in the single arm. But the in controlled, we have three types: sequential, parallel, and the crossover. So we have three types of the groups. Parallel, it's like we give this group a treatment, and the other group we give like treatment A, and the other group a treatment B, and we just we just observe what is happened and what are the results. Crossover, like we give the group treatment A, and the other group a treatment B, and then we cross that, like the group that we give A, we give them B, and that's it. Okay. And sequential, that's me, you give a treatment A, and then we give a treatment B to the same group, to group C, like that. Sequential, that's mean it's a sequence of the events. So we just finished the interventional. So the interventional is subdivided into two groups: controlled and uncontrolled. Uncontrolled, single arm, but the controlled, they are subdivided into three groups. We can say crossover, sequential, and parallel. Then we talk about the observational, and most of the observational, they are retrospectives. That's mean we just look at the past records, at the past history, at the past things. We just observe the things, and we just look at if there is a cause and the results and this stuff. And so we subdivided into cohort and case control studies, and we'll explain later what is the case control and cohort, and also the cross over studies. But we have to make sure that the case control study and the cohort study, they are under the observational, okay, but sometimes they can go outside of this mapping. The case control, that's mean one group is case and the other group is control, that's mean we can give them the placebo or something, and I will explain cohort. Then I make this map as these are the phases of a clinical trial. So it is start about the research, we make the research, and the research is about the target and the molecules. That's mean the molecules is the drug, and the target, that's mean the drug affect to which, like affect to the enzyme or affect to the receptor or affect, that is the target, and that is in under the research. Then it comes to the preclinical, and that's mean we just do the experiments on the animals to see the pharmacokinetics and the pharmacodynamics, but that is happened to the animals. So this is the first one, like a research, and then the preclinical, which we do experiments on animals. Then we come to the phase 1, that is occurs to the healthy individuals, to the volunteers, but make sure that they are healthy. And the number of them is from 10 to the 100 of the volunteers, and we name this phase human pharmacology because we do these experiments, or we give them this treatment because we want to see the pharmacodynamics, pharmacokinetics, tolerance, metabolism, interaction to the healthy individual, and usually the number is between 10 to the 100. Then we go to the phase 2. Phase 2, phase 3, that's mean we start to go to the patient. So the phase 2, it start to the patient, and we called it exploratory therapeutic or therapeutic exploratory. That's mean now we do the drug, or we give the drug to the patient, and we want to know how that is affect really the patient and how that is affect the disease. And usually the number of them is 100 to the 500 patients, and remember the phase 2 is a patient. Okay, so why we do that, we just evaluate these patients, explore the use of the target indication, estimate the dose of subsequent studies, like we make sure that this is the basic, or this is the best dose for this patient to have an effect on this disease, for example, the efficacy and the safety of the patients, in the same time the basics for confirmatory study, because the phase 3 is also on the patients, and it's important for efficacy and safety of the drug. So we can say it therapeutic confirmatory, so they are just depend on each other. But you have to focus that the phase 2 is on the patient, the number is 100 to the 500 patient, and we just explore if there is risk, if there is something that we didn't know it. We just describe what is the dose, what is the best dose, what is the best mode of the administrations, and this stuff. And then we go to the phase 3. About the phase 3, we just discussed that's important. The most important thing that you can describe the phase 3, that is important for the patient efficacy and safety. Efficacy, that's mean how well the treatment affect, or this drug affect the patient, and what is the effect of this drug on the patient, and how the patient improves by this drug. And the other thing is safety, which is the most important thing that all the clinical trial focus on. So we called it is therapeutic confirmatory. Usually the numbers is between 1,000 to the 30,000 patients, and usually they are patients, sure. And then we make the register, that's been in FDA, EMA, or this stuff, and we take approval from them, and we go to the phase 4, which is a marketing phase, and we can say therapeutic use, and that is more than 10,000 patients. That's all about the phases, and I confirm to you that we will describe it thousands of times during this lecture. Then we go to the what are the responsibilities of the sponsors and investigators. These are just many responsibilities, but I will talk in details in the upcoming papers. So what are the functions of the investigator? The investigator usually is a physician or a dentist, usually has a medical license, and he responsible for the treatment of the patient, collection of the data, and then transfer data to sponsor. That's so important to know it. So the investigator, it should be a physician or a dentist. And the other thing, that he's responsible for the treatment of the patient, he makes sure that they give them the correct dose, and make sure also they are a proper use of this drug, and then collect the data and transfer all these data to the sponsors. Then the sponsor is responsible for writing this protocol, write a report, organization of the study, and make the data analysis. So these are the responsibilities of the sponsors, but as I said, these are just many responsibilities, and I will talk later in detail what are the responsibilities, because they are just large, not small like this, but we have idea about what their responsibilities. Remember, I talked before about the internal validity, and I said that the internal validity should be in the outcome of a clinical trial to be effective. And about the internal validity, that means how accurate the measurement that we use it. Okay, so that is internal validity. And what are the threats to the internal validity? Actually, bias, confounding factor, and random error. Okay, so when I will explain about the bias, so all the threats, I can say they are just a problems that is making your outcome of a clinical trial, that they reduce the internal validity. So the first one is bias, and if I explain the bias actually is a systematic errors. Yeah, because I describe them, just the differences between the systematic errors and the random error. Bias is actually a systematic error. Okay, and it's when I said a systematic error, that's mean it's constant and predictable error. That's mean I just predict that error it will be happen because the calibration is not good, because I know that before. And unexpected and constant error, that's mean if I increase the sample size or decrease it, has no effect, and that is lead to the inaccurate results. Inaccurate completely. These are results are false completely because they are wrong from the beginning. And we can reduce them just by using the calibrated methods before data collection, like a proper calibration. Then we just reduce the systematic error, which is a bias, is a systematic error. Another definition of the systematic error is unexpected. We inspect this error and it's a constant error. It's not affected by the sample size. So if you increase the sample size, it's has no effect and the results is inaccurate. But about the random error, it's an error that happened by the chance. No predictions of this error, just happen by the chance, and it can be decreased if we are increasing the sample size, and that is due to the imprecise results, and that is different. That's mean okay, they are correct results, but they are imprecise. So we can maybe, okay, it's okay, we can accept these errors, but they are imprecise, and that is the difference between the random errors and the bias, which they are just two problems or two threats to the internal validity. So what are the types of the bias? So we have the first one is selection bias, and the problems is when I say there's a bias selection, that's mean how we just select the participants, and the detection, that's mean if we just subdivide it into two groups, and the measurement methods that we use it, like the one of this group is a treatment group, the other is control, like we use more precise measurements tools, more accurate methods, more like about the measurements method that we use. Okay, so that is detection. Performance, it's how we deal with these patients, and how we deal like with the controller group, how we deal with the treatment group, like we deal better with the participants of the treatment group, so the results it will be good. And then recall, like they have a problems in remembering what has happened. Observer, like the observer bias, like expect things and just do what is expect and just report what he's expecting. Attitration, when someone is dropped out from this group, like he withdraw from this group and he wanted to be in this group, and just we make the results and we just ignore completely this person that is out from this group. And then the publication, like we publicated the positive results only, we just ignore all the negative results, and that is the publication bias. And these are the, I can say that's so important because it's a good questions and important questions. What are the types of the bias? So we have selection, detection, performance, publication, recall, observal, what else, attitration. All these are, we can say they are these types of the bias. And then we go to the confounding factors, which is one of the threats of the internal validity. And what is a confounding factors? Actually, it's as I said, it's a hidden factor between exposure and the results, or we can say it's a variable that influence both exposure and the results and distort the absorber relationship. It's a variable that is related to the exposure, related to the results, but it's like distort the relationship. Like when I said, when just like a make observation between the coffee drinking and the heart disease, and just making a connection, and then I realized that some of the participants are smoking. So we can say smoking here is a confounding factor that is has influence on a coffee drinking and have influence also on the heart disease, and distort the relationship between the coffee drinking and the heart disease. And that's exactly what is a confounding factor. The random error, as I accept before, I just explained that before, it's the error that is happened by the chance. I didn't expect any errors, and that this error happened. That's exactly what is a random error. So these are the threats to the internal validity: bias, confounding factors, and then the random error. As I explained before, also the purpose of the clinical trial. So treatment for sure, prevention, like we prevent, as you know, it's that doesn't need at all explanation for that. So the purpose of the clinical trial, the first one is a treatment, prevention, diagnosis, screening, supportive care, health service research, and a basic science. So these are the importance, because maybe we just need a drug for treatment of a cancer, or treatment of anemia, or treatment of any other diseases that is so we are struggling for. And then the prevention, like we do lifestyle modification, for example, for diabetes. I'm just talking about the things that already that is present, but in a clinical trial we just discover things are new. That's mean exactly by the prevention. Diagnosis, how we diagnostic tools, how to diagnose the cancer so early, for example the pancreatic cancer. Screening, also the early screening is so important for the cancer, so maybe we just discover new tools for screening. Sometimes it's supportive care, sometimes it's health service research, like well, we will look in how the hospitals or the outpatient clinics like new methods of dealing with these positions, and then the basic science. So these are the purpose of a clinical trial. As I told you before, I will explain more details of difference between the case control study, cross-sectional study, guard study. I'm sorry that I'm just putting these things in Arabic, but it's okay, I will explain everything here. So the case control study, as I said here in retrospective, that's mean in the case control study it's observational. It just we look behind, we look at the past records and the past history, and we're just making a comparison, as a comparison between the people that they are affected by the disease with the people they are not affected by the disease, like between the patients and the control groups. And then through this group we can know what is the exposure, what is exposure factors between the patients and the volunteers. In the case control study, as its name shows, that we subdivided the groups into two types. We have case group and we have the control group. Okay, and we're just making a comparison between them so we can determine what is the exposure factor. Okay, but actually we can't make, and this is the limitation, like the problem in the case control, we can't establish the temporal relationship. We can say that is the exposure and this is the cause, for example, and that is the outcome. So we can do that by the case control study. And then we go to the in the case control study. Before I go to the cross-sectional, it's important that we use something is called odds ratio. And what is the odds ratio? It's equals exposure among cases divided by the exposure among controls, and as its name is case control, so that is used in the case control study, but it's important to know that it's called odds ratio. So what is odds ratio? It's exposure among cases divided by the exposures among the controls. So we use this in the case control study, and it's called odds ratio, and it's important that its limitation, it can't show the temporal relationship between the exposures and the results. And then we go to the cross-sectional study. It's like collections and information, and this is called cross-sectional, not like cross-sectional. It's collections of informations from group of people in determined time, and we like collection the information. And one example for that is like we have this city or we have this area, and we want to know how many people they are just affected by the hypertension, and then we call this study is called a cross-sectional study because just we focus on an area and we wanted to know the people that they are affected by hypertension in a certain, like in a time zone. That's why we called it as a cross-sectional study. And what is limitation? It's also it cannot establish the cause exposure relationship because we just focus on something like okay, and then it observes the single point in a time, and the best data collected is a point prevalence because we just collect this information in a certain area in a certain time. So the best data that we can collect it is a point prevalence, and we just not focus on the patients, so we can focus on something like hypertensions, all this stuff. Then we go to the cohort studies. In the cohort study is like watching group of the patients to know how this disease is a progress. That's exactly what is a cohort disease. Like we know these patients they are affected, for examples, by the diabetes or cancer or this stuff, and we just watching how this disease is a progress. The benefits, this study can show us what is the cause and what is the result relationship. So this is the best study to it's actually the best thing or the best type of the study that show us the cause and the exposure relationship. So we know something is called relative risk, and which is equals the risk in the exposed group divided by the risk in unexposed group. So we use it in cohort study. So an important things like we want to know for examples what is the difference between cohort study and the cross-sectional study. And actually cohort study is like we watching a group of the patients that they are affected by the disease, and we just saw how this progress. And what's important to measure these things like relative risk, which is equals exposures in the risk in an exposures group divided by the risk in unexposures group. So we can determine what is the relationship between the exposure and the results. But the cross-sectional study, it's not important to be as a patient. Maybe they are volunteer, maybe they are affected by something that is not like a disease. Okay, that's exactly what is the difference between these studies, and that's important to discuss them. Now we go to the components of trial design. Like we have to design this trial, but we have to know some important points to know how we can design this trial. It's actually we can subdivide it into allocation and randomization, and then intervention model and control, masking, plotting, outcome measures, endpoints. We can say outcome measures, they are just we call them as the endpoint, and then the study population. Actually, I will explain every single point about each point of this stuff because they are all of them, they are important, or we can say just they are components of the trial design. So the first I will start about the allocation and randomization. What are the types of the randomization? The types of the randomization, we have simple, block, and stratified. As you can see here is a simple randomization, and that's mean we just like selecting the people randomly. We don't know what their age, what their name. That's easy simple. There is no categories, there is no classifications of their patients, and we just choose them randomly. And about the block, it just we subdivided the participants into these groups of equal number of the persons, like of the people, we just like subdivided this group, and each group has the same number as other, and that's we call them a block because we are just subdivided into the blocks. About the stratified, we like subdivided these persons according to the age, to the characters, to this stuff. That's by the stratified randomizations. Actually, we reduce the bias because the stratified, because we don't we just like subdivided these persons according to the age and this stuff. So these types of the randomizations is good. So these are the types of the randomization. We have a simple, block, and the stratified. Then we talk about the methods of the randomization: IXR, IVRS, and IWRS. And I will explain later in details what is the IXR, but it's important to know that these are three are the methods of the randomization. So the first one is IXRS, and that's mean interventional whip and voice response system. And here it's interventional or independent voice response system, and here web response system. So IXRS, IVRS, IWRS, they are just the methods of the randomization. So we know the types of the randomization: simple, block, stratified, and we know the methods of the randomization: IXRS, IWRS, and IVRS. So these are, we can say, the methods of the randomization. So we explain one component of the clinical trial, which is called allocation and randomization. Now we go to the intervention, model, and control. So start about the interventional middle, and we said that the interventional, okay, we can start with the control arms. The control, it can be placebo, it can be standard of care, or it can be sham procedure. Okay, so about the control, that we give the patient a placebo, not the patient, the people or the participants, and we call them in clinical trials, we can call them as a subjects. And the placebo, actually, it's maybe glucose, maybe normal saline. It's something that has no effect on the body, and the participants, he just expect that is a drug and it has an improvement, but actually it has no effect. So that is exactly the placebo. And when I said a standard of care, that's mean maybe we usually the present drug, the drug that like the populations or the group outside, they are just use the same drug, and that's exactly the standard of care, like we use the previous drug or the drug that is present already in the market. And then the sham procedure, that's what exactly it's like. I show the participant that I do procedure, but actually I didn't do anything. It's like a fake procedure, and that's what we can say. We call it as a sham procedure. So about the control arms, we can subdivide it into placebo, standard of care, and sham procedures. And what is the pros and cons about the placebos? The pros, that a demonstration of efficacy. When I said demonstrations of efficacy, actually I'm talking about the new treatment, because if there is an effect in the placebo, we can saw how that is how that's improved, So the demonstrations of efficacy and absolute it gives measure absolute efficacy and safety by the placebo and minimize the expectation. How it minimize expectation? For example, I use this new drug, and for example in the case group, and then I looked at the control group, and then okay, make improvement, but it just like a little improvement. We can like the results, it's same, almost same as a control group, so that is minimize the expectation. So what is the pros of the placebo? That demonstration of efficacy, it's measured absolute efficacy and safety, minimize the expectation. What is a cons? The first one is ethics, because the cancer patients, he think that he just received the drug and there's will be an improvement, and then there's no improvement because he took just a fake drug on a fake treatment. So that for ethics, it's not good. And the other thing, that there is no comparative information. Like I didn't just compare between two things or two treatments, as I actually compare between a treatment and the other thing. I do not think so. There is no comparative information in this stuff. So we are finished now the control and the interventional model. So I refer back to the components of a trial design. As I said, the first one is randomization, we can say allocation and randomization. The other thing is interventional model and control. The other thing is masking and the blinding. And about the masking and the blinding, there is types for that. So we have a single blind, double blind, open label. I think the open label is the first one. Double dummy. Actually, double dummy is not so famous to explain about it. So about the open label, that's mean the participant and the researcher both they know the drug, both they know the treatment, know everything. That's exactly why I said open label. But when I'm talking about the single blind, that's mean the participant they do not know the treatment. They are do not they if they are received the treatment or the placebo, but the researcher does. And then the double blind, that's mean the both researchers and the participant they do not know the treatment. About the double dummy, it's actually about like groups, we give them the drug, you know, and then like the active integrant in a capsule and the inactive is in the tablet, for example, and then we just exchange that for the other groups. That's exactly what we call them as a double dummy. So the types of blinding and masking, we can say open label, single blind, double blind, and double dummy. So these are the blinding and the masking. Again, we refer to the components of the trial design. We said allocation, randomization, then interventional model and control, then masking and the blinding, and then the outcomes, or we can say end points, outcome measures, or we can say endpoints. So we have for the endpoints, actually we have types for the endpoints, and the types for the endpoints, the first one, these are the characters of the endpoints, because endpoints they are the outcomes measures. As I said before, they are the measurements of the outcomes. And what I see here, relevant, early diagnosis, internal validity, external validity, and that is remind me what are the characters of the results. Should be significant, relevant, internal validity, external validity. These are the characters of the endpoints. And then the types of the endpoints, primary endpoints, because they are just concerned about the primary goal of the clinical trial. They are just answer the basic questions of this clinical trial. It's the most important. And then the secondary, like the secondary topics that is related to the goal of a clinical trial. And exploratory, like we discover new something while we just observing this clinical trial. And there was something is called surrogate endpoint. When from its name, a surrogate endpoints, like for example, I'm just like observing the tumor, for example, and I just give it treatment, and then I observe there is a shrinking of the tumor site, and I'm just too fast that I'm just not waiting for the final results. And I said once this tumor is reduces in the size, so that's mean there is a survival in the cancer case. And that's exactly what is the surrogate. That's mean I'm just not waiting to the end and just clicking the early sign that show us that there is a survival in this cancer case. And that's exactly why we said that is a surrogate endpoints. And about the composite endpoints, so from its name, like we just collection multiple composite, because it just combines multiple outcome measurements in one measure. That's what exactly is a composite. And then we have the event driven outcome trials, like for example, we're waiting for a heart attack, or we're waiting for death, or we're waiting for something as a result, maybe serious effects. Once it happened, I just didn't give time zone for that. I'm just waiting to the happen and then finish the clinical trial. So there is no time for that, and that's exactly why we called it as event driven outcome trial. So when I said what is the type of the endpoints, they can subdivide it into primary, secondary, exploratory, event driven, we can say surrogate, composite. So we have different types of the endpoints. And then back to the components of the trial design, as we said, allocation, randomization, intervention model and control. We have also masking and blinding, measurement of the outcome, which we call them endpoint, and then finally the study population. So about the study population, we have here sample study population sample size calculation measurements. We have to make some calculation to choose the exact number for the study population. So we have here estimated the difference of the effect. Like if I want a large effect, so we have to choose small sample size. If I want a large effect, and estimate the variance of the group. So if I want large effect, so I mean exactly where I need a small number of the people, so I need a small sample size. But if I want more variance, just indicating the power of the group or significance of the group, so I need a large sample size. And how that's exactly how we can calculate the number of the people that they are should contributed in this group. So the difference of the effect, the variance, the power, the significance, and exactly what I need a large effect. That's mean a small sample size, but when I want the variance, power, and significance, I actually need a large sample size. And by this, we are finished the components of a trial design. As I said, allocation and randomization, intervention, model and control, masking and blinding, outcome measure, endpoint, and then finally the study population. So these are the components of the trial design. Thank you so much for listening, and I will continue describing summary for the clinical trial.